Hello and welcome to Take Three and Call Me in the Morning, where we attempt to discuss various health related topics from the perspective of a physician, a physical therapist, and a clinical psychologist. I'm your host for this segment, Dr. Pegah Magatam, and I'm accompanied by my esteemed colleagues, Dr. Vahid Yagane and Dr. Adam Holsworth. Today's topic is very near and dear to my heart. Pain, whether chronic or acute, physical or emotional, we all know a little something about pain and how to work with it. But first, our lovely disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Listening to this podcast does not establish a doctor-patient relationship. Always seek the advice of your physician and other qualified health provider with any questions you may have regarding a medical condition. Never disregard the professional medical advice.
Oh, it's still going.
Or delay in seeking it because of something you heard in this podcast. The views expressed on this are those of the hosts and guests and do not necessarily reflect the official policy or position of any affiliated organizations. Bam!
Wonderfully done.
Thank you. I even did this because it was.
Oh, calm down, guy.
Hey guys.
I know I am that good. All right.
The four options I have for sound, I guess one of them got stuck, so I had to exit out of the baseball sound. Sorry, guys. It will no longer be making appearances on Take Three. So
Oh, I like that.
you lived a strong life, baseball noise, but you are no more.
Goodbye, baseball noise.
Goodbye.
And I'm going to do what Vahid did last time. I'm going to go last. So, and I'm going to make Vahid go first. Bam.
What am I responding to? What do you want me to do?
What is your perspective on how to address pain?
Okay, yeah. So, I mean, pain is a huge one. So I'm going to just go with what first comes to mind. I would say first and foremost, probably in my area as a primary care physician, is validating people's pain is important, and not ignoring it or not minimizing it. Because in primary care, a lot of times, you might have someone complaining of a pain that sort of feels like it's out of proportion to what might have started it and whatnot. And I don't think anybody does this intentionally on my side, but you might think to yourself, is this really, is this really that painful? Or like, and then we live at a time where unfortunately there's a lot of misuse of pain medication. So you have that in the back of your mind sometimes. I would say less so in my case, because I get to know my patients really well, and that's not an issue. But when I was in sort of a high volume practice where I'm seeing people for the first time, just rushing in and out, that's something that comes in the back of your head. Is there actually pain, or could this be another issue? I would say with the pain, things that I look at is this like has there been an injury, right? Is there an acute? So short term, something happened, there was some kind of injury, and now there is pain. Is this a pain that's been around for months and months and months, maybe years? Those in my world tend to be neck or lower back or knees. With the knees, it's usually osteoarthritis for the most part. Low back and neck, it can vary, but again, it really depends on the case. Um, so, or then we also can enter a world of, is this kind of like pain all over, right? And there's no specific injury. Then we start thinking about things like fibromyalgia. Possibly, I would say that's probably one of the more common ones like that. Or is this specific to certain joints? Is it symmetric? Is it asymmetric? Because I also have to consider autoimmune conditions, right? That could be resulting in sort of multiple joints being affected. So yeah, there's a lot there's a lot going on with pain as a whole. I would say if we narrowed it down, um, that usually might take quite a bit of interviewing and questioning. Um, I would say in assessing pain, an important thing here is to have some kind of standardized questionnaire. I mean, I don't know how it looks like for you guys, and I'm curious, especially you, Adam, because I'm sure you deal with pain a lot more than I do. But um, is there the self-reported type of questionnaires, and there's several of them out there. I don't even know all of them. Um, and FYI, anytime I'm doing any kind of questionnaire, I'm pulling it up so that I don't miss anything. So I don't have any of these things memorized, but happy to share a couple of them in a bit if you guys want. But basically, we're assessing, the degree of pain that this person's having, trying to objectify it or be objective about the intensity of that pain as much as we can. I don't know. I'm sort of going off on a tangent. I'm trying to answer the question, but it's a broad one for me. So I guess that's a good way to answer. In my world, that could mean a gazillion different things.
So let me maybe if I can get a little bit more specific. And I know that, part of what we're trying to do here as a team together is to bring folks into like kind of what's happening in the background for each of us as people. Like we're people who are working with people who have stuff going on. I guess for me, what I would rather know about you is your own um, philosophy, just Vahid's,
Okay.
on how to help someone who comes in and says, "Hey doc, I've got this pain," and maybe we make it even more specific. So here you are, kind of in the lifestyle medicine world where you're helping people change their behaviors, right? And so that they can get to the goals that they want with their health. And they say, "What do you mean I've got to do X, Y, and Z? I've got too much pain." So here's this big boulder that comes between you and their success in whatever way. What is your strategy in that department? In that, how do you approach that person
Yeah,
now?
that's actually very helpful narrowing it down like that. So thanks. Um, so strategy is first, like I said, listening, right? Validating, listening. Okay, like let's talk about this pain. Like when did it start? How does it go and come? Is it is it intermittent? Is it on a scale of 1 to 10? Like how severe is it when it's at its worst? What things make it better? What things make it worse? Your typical sort of questions around any symptom that we come across in medicine. I go through all of those first just to understand the pain itself a little bit better, right? And any history that goes along with that. Things like, have they seen a specialist for these things? Have they seen someone like Adam already, right? Have they gone through that, or do they see a pain specialist, etc.? So let's say the example that you're giving me, someone that we want to incorporate a bit more movement in their day, but maybe they're having knee or low back or some kind of pain that makes that limiting. So once we've assessed it, then determining if we need imaging. We don't always. That's a misconception, that we have to image absolutely every joint that's painful. I disagree with it. Of course, I want to be sure I don't miss serious things, right? So if we're having pain and there's also neurological symptoms, things like that, I'm going to be moving a lot quicker to figure out what's going on or sending them to get maybe some more immediate imaging. The other aspect of it would be making sure there's nothing infectious going on, right? So things that if I missed would, like diagnosing it too slowly could be detrimental to them. So those are the things I try to get out of the way first. So let's say we did all of that, everything is fine, and we're dealing with like this chronic low back pain, for example. The approach to that is I educate. So it's really, really important for me to make sure that my patients fully understand what's going on and what the data out there, at least the current data, says about these type of things. Like let's say with lower back pain, right? Like what tends to work best. I am a big supporter of physical therapy. of core strength, especially when it comes to low back pain, of all of these things that are within most people's reach, um, as opposed to going straight into something more invasive, right? Like, let's say surgery or something of that nature. However, I don't think that there's very many surgeons out there trying to push people into surgery that they don't need either. So thankfully, I think even the surgeons are saying, hey, if you haven't done the physical therapy first, you should do that. So that's one of my first go-to. So most of the time, right after this person sees me, I want them to see a physical therapist, because my assessment is going to be different, right? I'm not as well versed as a doctor like Adam, and so I can get more insight, and then I can converse with them and say, hey, are we dealing with what I think we're dealing with, or is there something else going on? Is there something that we should be considering that I haven't considered? So that's always a good next step, because it's not invasive, because it's accessible, because it's potentially very, very beneficial. As far as treating it, when we talk about medications, right? So pharmacotherapy, we're always going to go for the thing that is going to have, um, for the medication with the lowest dose possible to achieve an effect, right? And we don't jump to opioids. That's more rare, right? You have someone established with maybe cancer pain or something like that. That's different. And even then, you're trying your best to sort of not go straight to the big guns, because then you run out of ammo, right? If you're trying to escalate your approach to this from a pharmacotherapeutic perspective. So I would say, as long as there's no contraindications, typically short term, we do things like non-steroidal anti-inflammatory. So that's like your Motrin or whatnot, right? Your ibuprofen. Um, if we can avoid it in someone who has a propensity for gastrointestinal bleeding, so let's say it's an elderly person who's already on a bunch of stuff, or if we can avoid it, we will. It's important to distinguish the type of pain as well. Pain that is more neuropathic, that sort of, think of, if anybody's had like shingles, for example, or anything like that, like that sort of like nerve style pain. It's like a more of an electric sharp type of, that kind of pain would respond more to a certain class of medications, right? Things like pregabalin, things like that. So the choice of medication is going to depend on the type of pain. Now, if I think the pain is because there's an inflammatory process and we go to a non-inflammatory drug, right, that makes more sense. Things like fibromyalgia, there's some data to suggest that we can use medications that we sometimes use for depression, like the SNRI, so serotonin norepinephrine reuptake inhibitors, right? So just make sure that you have more serotonin and norepinephrine around. So the ones that we do use for pain are duloxetine, and I want to say there's another one, but duloxetine is the one that I go to. It's shown some data, at least in the short term, that it can affect that kind of pain. So the type of pain really matters. You guys feel free to chime in. I feel like I've been talking a lot.
Okay, well, then we'll pause you here.
Yeah.
No, I'm just kidding. Let's just see if we can actually maybe integrate all three of us.
Yeah, that works.
So let's just jump over to Adam. Hopefully that felt okay to you, Vahid. I want to check in with you that you didn't feel like I just cut you off. But
no, I was. You just threw me a life a preserver. Thank you. Like I needed some help. I don't like hearing my own voice.
I think my question was a little vague, and then like the acute versus the chronic. I felt like, oh no, here comes the entire book of medicine.
Yeah, that's the tough thing about pain, is it's so broad, and that's why we see so many different approaches to pain. Some I agree with, some I definitely don't agree with. Ultimately, it's kind of whatever works, in my opinion, as long as it's kind of a minimal risk profile. But a couple of things I just wanted to throw out there so we could set the baseline of understanding, and then some interesting facts. We are currently dealing in the biopsychosocial model of pain, at least in my world. That's kind of probably the fourth or fifth iteration of us understanding the pain response. I can go into that a little bit if you guys think that would be helpful.
Yes,
but
100%.
Okay. Well,
Just don't take half of what I'm going to say.
yeah.
So,
Let me circle back around to that, because that'll take a lengthier description, and then I'll probably nerd out, and then there will be 5 hours that passed. The other interesting thing is, um, what is we consider pain the fifth vital sign now. I don't know if you guys have heard this concept, but outside of heart rate, temperature, respiratory rate, blood pressure, in the 90s, I believe it was, a couple organizations lobbied to have that as the quote fifth vital sign. I'm a little bit more cynical, so it is of my opinion that a lot of that may have come from the pharmacology world with the lobbying efforts. But maybe you guys can shed some light onto that for me. But I was just on a daily basis when I was working in network, every part of our documentation had to have a pain score, right? 0 to 10, what's your pain? 0 being no pain, 10 being take me to the hospital. Um, I never ask pain levels anymore unless I'm really trying to do a pre-post assessment intra-session with because of some sort of intervention. I think the focus is too much on trying to quantify the pain, and that takes away quite a bit from actually understanding the pain and how it integrates with the human and what they're trying to do, right? I.e., function.
Mm-hmm.
So I might ask, how do you feel walking up the stairs yesterday compared to 1 week ago, or something like that. We can get into at least my understanding of pain, how I like to educate patients on it with kind of the biopsychosocial. I'll just say quickly, that's kind of it. Think of a Venn diagram. You've got three circles, right? The biologic, the psychologic, and the social economic, we'll call it. And then our experience of pain, that is what it is. It is an experience. There's not a single button or nerve cluster or synapse that is, or even part of our brain that is the pain center. Typically, that little Venn diagram overlaps to create that experience. If we're talking electrochemically, we might get some sort of noxious stimulus. That signal will very often bounce around different parts of our brain, and we very quickly um, differentiate if we need to recognize that as a insult or a trauma or something that we need to act upon. That's why another way to think of this is how incredible the body is, right? How is it that we can feel a slight gust of wind or breeze or like a fly kind of tickling our arm, and then also be able to get shot in a war and not notice that because we have some more important things to do, right? What gives us that ability? The way I will usually describe it, I promise I won't go into it, is the whole circuitry with the ascending and descending pathways and what that actually does within the.
So I'm gonna interrupt and say, if you can go into it briefly, I think it's gonna be really helpful because that also speaks to chronic pain. If you're about to say what I think you're gonna say, which is we kind of discussed this one of our first conversations about when there's a trauma, like a physical trauma, because there's other trauma and pain are intertwined. So I'm sure, Pega, you're going to say a bunch about that because that is very important to distinguish. Is that once the injury has healed, how come the pain sticks around? And that was like probably our first recorded conversation. Is that what you wanted?
Yeah, I think
So
in
let's hear
order
it.
to allow some room for Pega, because I'm really curious on her thoughts, let me discuss this in more of a biologic way, and then I'll pass it on over to her for the other two, psychologic, socioeconomic components. So from a biologic standpoint, we may have some sort of tissue injury, right? Which is generally creating inflammation. That inflammation has some messaging signals, some metabolites that will increase the chance of our nerves sending an electrical signal. I won't go into how the nerves send an electrical signal unless you guys want me to, but let's just assume that an electrical signal is sent at a very specific time point based on an electrical gradient. So it's kind of an off and on switch, right? Depolarization. So once that signal is sent, it goes through this line of cells, of nerve cells. And we, to keep it easy, we'll kind of break it into first, second, and third order neurons. So the first street is that tissue, let's say my thigh, up to the spinal disc that is associated with that, right? Third, maybe fourth, maybe second lumbar level. So now we're in our central spinal cord. That is the junction between the first and second order neuron. And then, as you guys know, between those neurons, right, we get that electrical signal. It gets to the end. It releases some neurotransmitters from the vesicles. Those vesicles bind onto the next cell to create that chain of electrical signaling. So there is a gap there. That gap is important to remember, right? Because that's how we can influence it, maybe turn the knob down a little bit. But we get into the second order neuron. We're going up to the brainstem, midbrain, and then that is where the second and third order neuron junction is. And then from there, we're usually going to the somatosensory cortex, which is kind of the sensory map in our brain. If you guys ever want to look at a terrifying thing, you can Google homunculus.
Yes, I love the homunculus.
Yep, pretty. I know what I'm getting you guys for holiday gifts this year. Awesome. It's got to say equalizer on it. But that is how we can associate some sort of sensation with that specific body part. Now, that took me a while to explain. Would you agree? So imagine all of the energy that our body needs to use to send those signals from my thigh all the way up to the part of my somatosensory cortex that is responsible for my thigh. It's a lot of energy. So what happens a lot if we shift over to chronic pain is we are very good at adapting. We're very energy efficient beings. So eventually we're going to say, okay, I keep getting this signal from the thigh. I can just cut out the two middlemen and just have this up in my cortex, in my brain, where I don't even need to go through the spinal cord. I don't even need to go through the peripheral nervous system. It's just kind of a closed loop. So the issue with that is when that tissue injury heals, right? They will typically heal. Then you have to kind of go back around and figure out, okay, how do we break down that now closed loop process? And I bet I'm interested to see. I bet that's a lot what PEGA deals with. I'm curious to hear that. But that is the biologic, right? The ascending or moving upwards. And I'll cap it off with the descending component because that's really important. The descending is the circuitry or the wiring that will flow down, and it's typically integrated in between the first and the second order neuron. So the peripheral nervous system, right, the nerves from my leg, and the lumbar spine, the beginning of the central nervous system. So you could get that downward channel that can influence or release some positive or negatively charged ions that can basically turn the dial down so that electrical signal is not passed, right? So you can kind of block it almost. That's a lot of what some of those medications you were describing do, the mechanism of action there. There are other ways as well, from like some CBT, some mindfulness things. But I think it's important I find it important at least, for our patients to know that we have the building blocks and the circuitry to control our pain. And there's way more than just the tissue part of it, right? Mm-hmm. There's way more than just the physical sensation of your cells. This is, something that PhDs have studied for centuries. So forgive me if I messed up any of that, 5-minute spiel, but that's kind of how I like to at least set the building blocks and the standards for educating a patient. And just on a quick side note, as a clinician, this is a conversation that I really want to have when I've already developed rapport with the patient, and I can allot some one-on-one time. I can do that now all the time, but back in a busier clinic, it's really important to do that because About 50% of the people, if you don't make it more of a conversation, they will come away with that saying, "Oh, you're telling me that the pain is in my
Oh,
head and I'm making it
mhm.
up," and they get very angry. So, if you're a clinician out there, yes, I encourage you to understand more of the mechanics, but also understand the human being that you're trying to impart this information to, and really allow for a comfortable environment and a discourse. Because that, pain education, we call it like PNE, pain neuro education, can have a pretty negative, drastic negative effect on a lot of people if not done properly.
Mhm.
Yeah.
Yeah.
Over to you, Pega. Fill in the gaps of psychologic and socioeconomic. Tell us why this earth is doing so well right now.
Exactly. I'll just fill in some of the blanks, but the conversation is already so rich, and there's so many parts and pieces to this, and it's almost like you kind of somehow knew every question on my exam in graduate school for getting licensure, and you got it all right. It was very weird, Adam. Like,
Robot Atom has achieved full
yes,
mass.
exactly. It's the craziest thing. But anyway, so I wanted to kind of speak to the vital sign, the fifth vital sign. I'd never heard of that before, but that makes a lot of sense to me on a personal level. Um, Super long story short, I had a microdiscectomy back in 2015 on the uh, oh my god, L4, L5, L5S1, L5S1, I think, spine. So my disc had herniated, and I just remember it's funny because with pain, it's just so much shock to the body that I have very specific memories. The day it happened, January 5th, the day I went to my uh, primary care, February 12th, my day of surgery, April 20th. Like, these memories are so vivid in my head. This is how I know that trauma is built right into those experiences. But February 12th, I remember going to the doctor, and I said, I am in an extreme amount of pain. And you said heart rate up, yes, temperature, yes, respiration, all over the place, blood pressure through the roof, to the point where they had to give me a shot to manage my pain. So it makes sense that this would be built in, because in my mind, I'm like, I don't know that if there's anything different between what I was experiencing and something that would be considered, you know, an emergency, going to the ER. So I don't know, but from my personal experience, that pain got to be so high where it, you all talked about it, that nerve need the block needed to happen in order to break the cycle I was in with pain. So, putting that aside, there's so many things from I'll just come in from the perspective of the psychologist. So, typically I'll have folks who come in and say they've likely been experiencing some kind of chronic pain. So there's some kind of chronicity to their pain, and I'm looking at it from the angle of how do your emotional or psychological concerns interact with this pain. And typically they usually don't. They think I'm a little crazy, which is fine. I don't mind at all. But that they can start to tell if I'm talking about stress. That point in my back that typically starts to hurt will start to hurt in session. So even talking about their stress is going to trigger the pain response in their body. And I just kind of very casually say that's not an accident, that these are highly related things. And typically, what I will say when a client is working with me in the room is that as long as it's coming up now, it's relevant. Now, do I also say, hey, we need to make sure you get a referral to your physician, you need to get a referral to physical therapist to make sure we know what's going on? Absolutely. But typically, they're usually in some kind of physical type therapy while they're seeing me. And I think those two things go very well
Mhm.
together as adjuncts. Um, but we then go back into working with the pain. Like, so you sort of said, Adam, mindfulness, CBT. One of the issues about pain is that it gets re-upped in the brain. It gets reignited in the brain. And it actually has quite a social component to it. So, and we start to sort of break those things down if the client can tolerate it. If they can't, or if it feels a little too heady or a little too academic, I just don't do that quite yet. But a lot of times as the clinician, when I'm looking at them, I'm going, what about this pain pattern is reinforcing for you? What I mean by reinforcing, that's a clinical term, but what makes this pain stay relevant in your life? So for example, you can look at it from the angle of, let's say there's um, a couple. One person in the couple has chronic pain. The other person in the couple responds to that pain. And so every time the person says, ow, my shoulder, guess who's right there soothing them and comforting them? Why would this pain want to go away if what I get is love and care from my partner? So it doesn't mean that it's necessarily conscious, but it's serving a purpose. So that's one thing about this loop in the brain. What purpose does it serve you? The other thing to keep in mind is my own relationship with my pain. We talked about last week my relationship with food. Now we can look at what's my relationship with my pain. What is it that I say to myself about myself when I am in relation to my pain? A lot of times in the world of CBT, they'll say, do I look at my pain and I think I'm a failure? Or this is a challenge that I can overcome, or nothing ever works out for me. So if you think about it, that's why I kind of said to you, Vahid, someone comes in and they say, well, you want me to do what? Move my body, but I've got all this pain, right? So right there, they have some kind of a relationship with that pain. And that pain starts to become part of who they are. And you might want to separate those things out with them and to get a better understanding. If this huge boulder in front of me that prevents me from being able to get what I want is my pain overpowers me, or because of my pain I can never get what I want, then you have a very real psychological component to work through with them collaboratively, helping them. In my world, we say, internalize your locus of control. You'll hear me say that a lot, because when a person feels that they are disempowered by anything, and then they're not going to really see themselves as the agent of change. But the second I see myself that there's something I can do here, that I do have some kind of control, then that relationship with the issue or the pain starts to look different. Now, that doesn't mean that I'm going to become an Olympic athlete tomorrow, nor do I want to, but maybe I can increase my activity slowly. Maybe I can feel successful in some areas of my life, and that starts to build on itself. And I think that does help to mitigate some of that experience of pain.
Can I ask you a question?
Sure.
So I find or see that quite a bit where, to your point, a client or patient has a lot of positive outcomes from displaying pain.
Mm-hmm.
To one of your earlier point, like a more attention from their spouse or something, or sometimes in the workers' compensation world of things, like you might be getting paid to be out of work. That's a pretty motivating factor to consciously try to identify your pain as unchanged. So if when you find somebody with positive, I don't know what we would call it, positive outcomes or external output associated with their pain, how would you go about treating that? Or would you even want to treat it? Or are you trying to see like, okay, what's the most beneficial for this person?
Yeah, that's such a good question, and it's actually what you said, Adam, about you really have to build a relationship with a person. It's because you can really run the risk of losing them. In that it can feel very shaming if I were to sort of say, um, "What is this?" In our world, we call it, like maybe similar to you guys, the secondary gain. What
Yes.
is the
Yeah.
this thing you get that you didn't even realize you got? And now here's your doctor, your physician, your therapist, your whatever saying you're getting something out of this. It
Yeah.
feels very dismissive.
Yeah.
So that would be the first place to start, is to just help them to kind of understand, like, first normalizing it. Again, maybe wouldn't necessarily have this level of conversation just yet, but I would if it becomes something that's more chronic, like there's a chronicity to it, not the chronic pain, but like the pattern that they're stuck in, and kind of asking them to consider. And I do this all the time with my clients anyway, but what is the benefit to this? And then they might say, there is no benefit to this. What are you talking about? And I said, okay, let's just brainstorm together. What I know it sounds really strange and kind of weird, but can we come up with something? Can we just come up with something that we can think about that actually benefits you? And then they get to decide and kind of, again, internalize that locus of control and responsibility of, what would I do? Is there something that I want more than this? Whether it's the workers' comp or the affection I'm getting from my partner. And if it is the affection that I'm getting from my partner, what can we do differently? And that is actually some work that people in the pain world, in the psychology pain world, will do, where they will say, let's try not to attend to pain behavior. Let's try not to soothe it, because the more you soothe it, the more likely we are to engage that, re-up that behavior. So I'm not sure if that helps, Adam, but I would definitely ask them to be a partner with me in that, collaborate with
Mhm.
me. Is there something you want more?
There's the other side to this, if I may throw that in there, is you have the type of individual that probably has a lot of pain, but says, no, 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 I don't want meds. I don't want anything. I'm just going to grit my teeth and bear it because, why am I making such a fuss? Right. And so they're in a lot of pain. And those are the folks who I try to convince, like, let's get ahead of the pain so that you can actually work on getting rid of the sort of the root cause of it, right? Like what's causing it in the first place. Maybe it's somebody who has a weak core and just years and years and years of not supporting their spine well. And correct me, Adam, if that's not common for low back pain, but I find that at least in my experience, it has been. So with those folks, you actually have to discuss the other side, which is like, look, allow yourself to be treated for this pain for now, just so that you are pain free enough that we can get some movement going, because the movement in and of itself is what's going to help you long term get rid of the pain, right? You're going to bring blood flow to the area. So that kind of is also a little bit of the answer to your first question to me, Pega, is um, what would you do if someone says, yeah, but you want me to move and then I have this pain? It's like, well, if we get you to move, if we find a way that you can move, it will actually decrease the pain. So you'll have the opposite effect of what you think. But anyway, I wanted to throw it in there. There's the opposite type of person too, that will minimize their pain and how they describe it.
So I will say this, and this is a big part of what I do on a day-to-day basis. Probably the core of what I do. You said grit my teeth and bear it. And when you grit your teeth and bear pain, probably, Adam, you can give us the neurochemistry in this. It actually creates more of the pain cycle. So if I am gritting my teeth, I am actually bracing against my pain. The pain is there, and I'm going, ah, I don't I don't want. What I'm actually doing when I'm gritting my teeth and bearing or bracing is I'm actually pushing against pain. I'm resisting pain. When I push against pain, the muscles around the pain, or whatever, you, Adam, please fill in the blank. I feel like I'm stepping into your territory, actually tighten right back up, and the pain stays there physiologically, mentally, and it actually could get worse. So the antidote to that is to actually relax around the pain, to release the tensing of the muscles around the pain. And that's where mindfulness strategies can come in. That's where I would even, fire up one of my scripts and send and read it to a client and see how they can work with the pain in the moment. And just you'll hear me say things like breathe into the pain. You'll hear me say, okay, notice the pain, try to see what happens instead of pushing it away, or trying to grab hold of it, just let it be. And typically, what happens is that the body relaxes and the pain, the experience of the pain is actually diminished. Now, that doesn't mean that that's what happens when they leave my office. So I'll send them a script in their, voice app on their phone, and I say, try to listen to this. Apps like Calm, or I think Headspace, or whatever it was called. Those are very, very helpful in helping to reduce the suffering around pain. But I kind of thought about you, Vahid, and I was like, well, if you have them do that and now they are able to move their body, now they have to go exercise. Why would I want to do that thing? So I thought about my own process of like a person who maybe is now going, but you want me to go out there and move my body? I kind of don't want to do that. Why would I want to? And then that's the next layer of the work I think we would be doing with our clients. But let me pause there. Adam, are you
You want to talk about guarding? Because I think that's what Pega is kind of describing.
What?
Yeah.
Yeah.
Guarding happening. Yeah, no, I think this would be a good time. I don't know how I became the team nerd here, but we're gonna get nerdy, guys. So take a deep breath. Bear with me here. I think this is a good time to talk a little bit more about depolarization thresholds. You guys excited?
Speaking
Yes.
of pain, this is going to
Yeah.
be painful. Yeah, that's
You son of a bitch. You got me. So we have a very there's a difference between things happening within a cell and outside of the cell. And we have an electrical gradient, right? There's generally at rest inside of the cell is more negative. For sake of argument, we're going to say it's negative 70 millivolts. Got it? So outside of the cell, free floating, we have a lot of positively charged ions, right? Sodium, potassium, magnesium. We have membranes, little doors on the cell membrane, voltage gated or ion channels that will bring positive ions into the cell, and it will make the inside of the cell less negative, right? So it might go from negative 70 to negative 50, or negative 50 to negative 40. Generally, the depolarization threshold, which is an all or nothing event, the electrical signal or whatever the cell is meant to do, does that thing. You cannot stop it, is around negative 40 millivolts. Okay. So once enough positive ions come in to make that internal electrical gradient minus 40, bam, something shoots off. That signal shoots off. Nothing you can do to stop it. And then we have to pump and regulate, and everything goes back to that. To Pega's point, when you're tensing, or if you've had chronic inflammation or a long history of pain or any number of things, your internal cellular environment might not be at negative 70. It might be at negative 50. So now you don't need nearly as much pumping in of those positive ions to get that snapshot, right? So we can think of that as a hypersensitive or an overly sensitive fill in the blank nerve cell. But to your point, kind of tensing or preparing physically or physiologically, that is your muscles doing exactly that. You're kind of readying your system to send off those signals. Now, there's a difference between like the cellular level and the macro level, but we don't need to get into that. But I just wanted to jump in there and give kind of some biologic context to the things that you're saying there.
Love it. This is why we're here.
Um, I don't remember the other question you asked, but I got too excited about depolarization thresholds.
Well, um, do you remember, Vahid? Because
I don't know. That's why I was chuckling, because I'm like, was there another question?
I do
What?
want to make sure we speak to, because I was so appreciated last time, Vahid, that you spoke to food scarcity and food deserts. That was just so significant and important, and I appreciate this time, Adam, you brought up the social of the biopsychosocial and the socioeconomic component. Um, I am gonna kind of see if one of you can sort of take it on. I need
Yeah,
to wrap my
absolutely.
mind around it, but
I'm going to say it, and as soon as I start talking, I know your neurons are going to start firing. Those
don't look at my neurons.
the millivol, yeah, your neurons are uncovered. Um, so we know that adverse childhood events, right? So traumas that occur in your childhood, as the name suggests, are related to pain. Essentially having chronic pain when you get older, things like fibromyalgia or just in general some kind of chronic pain, we know that that's related. And I feel like that's pretty much because trauma as a whole and pain are so intertwined. So as I'm saying that, I'm sure there some thoughts are coming to mind for you, Pega. So how does that tie into socially? Well, people that are at a social disadvantage tend to have more adverse childhood events, as much as I hate saying that. It's the reality. um, it- just looking at the numbers, right? And so that also kind of ties into your social determinants of health as a whole, right? Access that you have to things, right? Access to transportation to get you to the help that you need, or access to the place that can give you the help you need, or like we spoke about what you just mentioned, access to food, etc. So there's a lot of uh, items in the social determinants of health that also kind of tie in here. One thing that I'm taking away from this, which I knew coming into this conversation, but it's just becoming more and more solidified for me, is pain needs to be approached in a multidisciplinary way. Um, Absolutely, because I can just see how much it overlaps, but each of us are approaching it slightly, I wouldn't say differently, but from a slightly different angle. Um, and I think if someone's dealing with a chronic type of pain, they would benefit from addressing all of it. Like as Adam said, the whole biopsychosocial nature of it, right? So they might come to me to get some medication to sort of help decrease the pain initially, um, and do some therapy, both physical therapy as well as psychotherapy, or even EMDR therapy, right? If it's there's some trauma related to that. But I don't know. Did that sort of trigger anything for you? Do you wanna expand on some of what I just said, or?
Oh, I think you did a phenomenal job with it, and I'm so glad that you remembered that piece, because it's such a significant piece. I just think that it's an important piece of the puzzle to keep in mind, especially when what you started with, Vahid, which is like the burned out provider who can inadvertently dismiss a client's pain or patient's pain, because they've heard it so much that that individual's pain is subjective, and subjective doesn't just mean it's all in their head, but that they really do have a unique experience of pain that's good, that taking into account their entire history is important. um, and sadly and unfortunately, like you said, with the adverse childhood experiences, when that lays the foundation of your life, trauma begets more trauma. So now something that might be experienced as otherwise, sort of brush your shoulders on off and move on in adulthood, for someone who hasn't had these kind of childhood experiences, that same experience is going to feel like a magnitude of 10, 20, however you want to say it, for someone who has had those experiences. So this is where EMDR can be so powerful in what we talk about in EMDR. These are our little kind of phrases, but your past is present. The past and the present are always connected. So when you're seeing something in the present, we're always tracking it back to the past of where the origination source of that experience is, and working through that um, to help people, feel less overwhelmed by what they're experiencing in the present moment. I feel like I can go on forever about this. Um,
It's a big one. Yeah, it's a big topic. I will say I can mention a couple of quick things about lifestyle, which are pertinent to pain. I would say, I've mentioned before the pillars, that we look at, pillars of health in lifestyle medicine. One of them being sleep. That's probably one of the most powerful things here as it relates to pain. If we're not getting adequate sleep, if we're consistently sleep deprived, we know that this can result in higher incidence, so higher likelihood that you'll have chronic pain or that your pain will be more severe. Um, Stress reduction, we know, so that's through things like CBT, cognitive behavioral therapy, or ACT. And you gave me a book on this that I'm still working through. Acceptance and commitment therapy. Okay.
Good job.
Uh, um, and what else from the pillars? I mean, food, and if we can, the stress ties into this as well, but just decreasing overall low grade inflammation in our body, right? So making sure that we're eating things that are not spiking low grade inflammation in our body, like ultra processed foods, but also with decreasing our chronic stress, we'll also achieve a similar effect. So there are a lot of things, and then movement, right? So physical activity, again, that is completely in Adam's sort of area of expertise, is all about that. How do we, what is it that you said? How do we get, pick the stimuli necessary to achieve the effect? I mean, I'm butchering what you said earlier on, but yeah, all of that. I mean, that's lifestyle, right? Like how you move, that's all your lifestyle.
I would like to reward the listeners at this time if they have made it all the way here, and I would like the three of us to try to give some action points on somebody that might be dealing with, let's say, chronic pain. Let's say they have had this nagging pain for more than 3 months. What are some, you already talked about it, but how would you approach that? What is something somebody can do without even seeing any of us or a specialist? What can somebody do on their own? I'm going to go ahead and steal all your thunder, Vahid, because you kind of already talked about it, but I really like what you were speaking to of, okay, let's maybe make a checklist and let's write out those pillars. Movement. What am I doing for movement every day? Am I moving every day? Am I walking for 20 minutes? Am I doing resistance training? Whatever. Nutrition, reflect on your nutrition and hydration. What's my stress like, right? So just reflecting on the pillars, right? So, and just to give complete list of the magical Vahid pillars, reducing toxic substances, sleep, and
Physical activity. Okay, yeah, movement, physical activity.
yeah, I got those.
Healthful nutrition, so good nutrition.
Yep.
You already said sleep, chronic stress reduction, and
Yep.
positive social connections.
Positive social. I told you guys last time that's the one I'm worst at. Of course, it's the one I wouldn't remember.
Yeah.
So I feel like that's a great way just to start to recognize, like, that's if somebody did that, they would have done hour one with Dr. Adam Holsworth, right? So you can check that off. What you have to pay a professional. What do you guys think?
Yeah, I would say actionable steps. Make sure you're getting a good night's sleep. Movement that you can tolerate. I tell everybody, if there is pain, don't move through the pain, but do some kind of movement that doesn't exacerbate the pain. Everything you just said, making sure you're eating well as well. Actionable steps on my end would be that, and don't be afraid to seek help. Most, I mean, a lot of folks are like, I don't want to go, and that means that, again, the more I think about this in real time, I'm thinking, yeah, I should be referring every single chronic pain patient both to psychotherapy as well as physical therapy, potentially pain medicine, depending on the severity and what we're dealing with. But actionable steps would be seeking help, and I guess to summarize kind of what you said, is checking in with yourself, right? Like sort of evaluating.
Yeah, even to see who the hell do I even start with. So I feel like going through your pillars and making a list and seeing what are the big red flags, right? Is it a stress reduction thing? If so, I'm going to go see Pega and work on this as a positive. You know what I mean? So I think that's a good. I think that's a solid action step. All right, your turn, Pega. Wow us with your action items. This better change my life, or
It will.
going to
It
be
will.
consequences.
Okay, watch this. So just sort of in this moment, see if you can kind of scan your body a bit and notice if there's any area of physical pain or tension. Sometimes we don't even realize that we're tensing a part of our body. And as you're sort of scanning through, it could be, tensing your calf or your left toe. And now, as you're noticing that, sometimes like your shoulder, your neck, usually that's what people do. As you're noticing that, your default response might be to want to ward it off, push it away, kind of do that. I think you called it guarding. I call it bracing and pushing away of that experience. And now bring the opposite response to it. Try to sort of turn toward it, notice it, let it be there, breathe. Actually, in a way, we're asking you to befriend your pain. Just breathe around it. You can even, I know these things are silly, but even imagine you're breathing into the part of your body that's in pain. Breathe in, sort of relaxation. Breathe out just a little bit of that pain. That's probably something I would love for people to try. So,
And I don't think it's silly, by the way. Yeah.
thank
Oh yeah,
you.
There's a lot of evidence behind it. So.
that's a body scan, and if people want to just type in YouTube body scan or mindfulness body scan, there's, I don't know, tens of thousands of videos. That's such a great idea. I'm really glad you brought that up. That is a amazing thing that people can try to do, and I feel like you need to just record your soothing voice and upload a body. Oh, you do? All right. Well, Pega body scans
You're not
available.
going to be able to monetize that, Adam. No, I'm just kidding.
That is amazing. All
In
right.
the interest of time, I do want to shift to and thank you, Adam, because you kind of brought in an example of a question that a client might ask us or patient might ask us, which is, what can I do today? Right. And so we gave them something. But in the just for our little fun, silly segment, I liked that I had a question, but it's a little too deep. So I'm going to go with something Vahid mentioned before, which is the song that when it comes on, you dance every time. Come on.
I don't dance, guys. Have we not talked about this yet?
No, we do have. Yeah.
Yeah, I feel like I've told you this.
So maybe you don't dance, but it makes you want to, even if you don't.
Some
I'm
things
going
make,
through my playlist. You see,
some things make me want to lift weights or like bury
What
a
is
deep
that?
that
squat.
works. That works. Yeah.
But the also the other thing you need to know is I am horrible at names of everything, people, song titles, roads. So I'm not going to be able to tell you that. I could tell you the key signature. Would that
Okay.
help?
Yeah. Why don't you sing it?
Because it's heavy metal, and I'd be screaming at you guys.
Awesome.
What about you?
Um,
What's your song?
it's gonna for always and forever be Dancing Queen.
Okay.
Yeah. When that comes on, I don't care where I am or what I'm doing. I'm probably singing it in karaoke, but I will be up and twirling. So get out of the way because I'll be twirling.
For me, I'm actually trying to see if I can find the specific song, but there's a trumpet player called Ibrahim Malouf who I love, and some of his sort of more jammy, less slow songs are they really, I don't know, they do something to my nervous system, and it just makes me wanna move. I mean, there's a lot of them. So if somebody wanted to look him up, Ibrahim Malouf, this one album called Capacity to Love, I think is one of the more recent ones. And then I think this one, which has like Portuguese vocals over it, is El Mundo. So that one, if I'm remembering, because I'm not good with song names, I just kind of play them. But anyway, Ibrahim Malouf, there's a ton of his songs that just get me moving. Yeah,
Sounds good.
Yeah.
Well, thank you guys. I think I've got to do the end disclaimer. I just lost it, so that's fun. Okay, hold on. All right, here we go. Are we all set? We'll see everybody next week.
I'll say one thing, which is perfectly timed with the disclaimer, is don't ignore your symptoms. Like if you're not quite sure, I would say go get checked out, because you want to be sure you're not missing any red flags. Anyway,
love it. Absolutely. And also, this podcast is for informational purposes only and does not constitute medical advice. Always consult your healthcare provider.
That's it.
Yeah.
Oh, I was expecting more. Thanks, guys. Love you, everybody.
Thank you.